It's really an honor to be invited to the third national conference of the Academy of Regional Anesthesia in India, and also it's truly an honor to be asked to deliver this lecture in memory of Dr. Bhatt. What I'm asked to do is to talk about ultrasound. That has been my interest and passion for the past 10 years, and I am asked to talk about the future. What is ahead of us? So this is the topic of what I'm going to talk about. First, I need to tell you I receive equipment for support from these 4 ultrasound companies as a disclosure. Also, I want to invite you to Toronto next year. Those of you who are beginning to learn ultrasound, we are going to talk about ultrasound for regional anesthesia, for pain medicine, and also the use of ultrasound in the perioperative period. So June is a nice time to visit Toronto. It's not cold, it's a warm and nice time. So if you have time, please join us. I think when we want to look at the future, either we have a crystal ball, we can look and see what's ahead, what are the new frontiers ahead. I think before we can do that, we need to look at the past, what we have learned yesterday. Why do we need to have a new technique of doing regional anesthesia? We also should look at today, the present time. What have we learned already? And then realize what we need to learn in order to further improve our skills. And then with that in mind, we can have an idea of what is coming ahead. I think what we already have learned something about Dr. Bhatt, and I have learned because I was reading this book, The Game Changer in Trauma Care, and it's a wonderful tribute to this wonderful legend in regional anesthesia. There is much to learn from him. I know that he is a great clinician, he's a great teacher, and most important of all, he was a great human being. And one thing that struck me when I was reading this tribute is the passion and compassion to patient care came before personal pleasures. And when we are going to learn ultrasound, I think there are 2 things I learned from this statement, this comment. I think we also need to learn ultrasound not just as a new tool, it's not a toy, but how we can use ultrasound to improve patient care. And second is the passion. If we are serious about ultrasound, we would need to inject some passion in learning how to use it properly. So those are 2 things I learned when I read. What about the future? Sometimes it's hard to gauge the future. We can speculate, but also we may need to ask someone who was already there. So this is the conversation between Steve Jobs and Bill Gates. Bill Gates wants to know what is heaven like. So then the answer to him is a perfect place, but what it doesn't have is any wall or fence. So what? Bill Gates asked. Well, in heaven we don't need any windows and gates. So I think sometimes we have some humor into this conversation. So first of all, let's look at what we know today. I think that the data today tell us what is ahead. And I believe the future for ultrasound is it will become a standard practice in anesthesia. I'm not only talking about regional anesthesia, but anesthesia practice as a whole. I believe that it will be incorporated as part of our basic skills. So why do I say that? I think so far we have used ultrasound mainly for interventions. We see the target, we help us to stick a needle in. I think it's very clear that for vascular access, particularly for central line placement, it is very clear, at least in North America, in Europe, it is now a standard practice. This is a nice article published recently in Anesthesia and Analgesia. It went through a very comprehensive review looking at adults and pediatric practice For internal jugular vein, there is no question, real-time ultrasound will reduce the incidence of complications. Again, why do we use it? Because we want to decrease complications and improve patient care. For subclavian venous access, there is no good data at this time to support the routine use. And for femoral vein cannulation is mainly to help us to identify the vessels. So now there is good evidence to use ultrasound for central venous access at in the neck. This article also came recently, appeared in New England Journal of Medicine, and what we now do have is different small size ultrasound machines, and it becomes very available. We can use it for point of care. And this article points out ultrasound will become an extension of physical examination. It is commonplace in most medical subspecialty, and I think it will be the same for anesthesia practice. So what we are seeing is also a revolution, is the advancement of technology. Things are getting smaller and smaller, and I think very soon we will have one in our pocket at a reasonable price. I think that is the future. What can we use ultrasound for in anesthesia? I want to not limit the discussion to regional anesthesia, because ultrasound is a good imaging tool. We can use it for airway examination, for the lung examination, for vascular examination, including the heart, and the abdominal examination, for example, the stomach. So there are many, many uses of ultrasound in anesthesia practice. How much we use the technology is up to you and me. If we are willing to innovate, if we are willing to use it and learn how to use it, we will apply to many things in our practice. In our center, we began to experiment and look at the utility of ultrasound in looking at full stomach, because before we are only asking the patient whether they have eaten or not, and we have no idea how much food is in the stomach. But so we can now see fluid, we can see solid food in the stomach to help us. We all look at the airway to examine the airway, and also learn how to do the transthoracic echo at the bedside to help us to assess the cardiac status before patients coming for anesthesia. So all those things are possible. For pain medicine, I know some of you are doing pain medicine, and again, it is not just an imaging tool to help us to place a needle. That is a small part. What is expanding is this area. For musculoskeletal imaging, patients come in with shoulder pain. You want to know what it is due to. Is it rotator cuff tear? Is it synovitis, tendinitis? All this can be screened, scanned, and examined by ultrasound. So that is another major area that is coming up. There are now many information, a lot of information on the website, and also published books. Now let's look at regional anesthesia. I think ultrasound, I understand that in this country is beginning, which is good. I feel the enthusiasm here today as what I feel about 4 or 5 years ago in North America, and that is very good, because over a short period of time, people are learning and they are convinced ultrasound is good for regional anesthesia. It didn't take too long for ultrasound to be embraced by the community compared with nerve stimulation. It took quite a long time, because not many people believe that nerve stimulation is better than paresthesia technique. I think for ultrasound, although it is more expensive, many people truly believe that it is the right thing to do, because it allows us to see the needle, it allows us to see the nerve, it allows us to see the local anesthetic spread. Those are the things that nerve stimulation and paresthesia techniques cannot provide. There are many skeptics. I know that there are skeptics in this audience, and which is very healthy and good. So that's why there are so many systematic reviews, meta-analyses that have been published over the years to show that ultrasound can be better than nerve stimulation. But what is most important of all, I believe, is your personal experience. It's not what is published, because usually studies are performed by the experts. I think what is important is when you use ultrasound, what it means to you in your practice. If it can improve the success rate in your hand, then it is a good tool. Also, what ultrasound has done, I've seen in the past few years, is it has expanded the practice of regional anesthesia. More and more centers are using ultrasound to do regional anesthesia and can benefit our patients. I think that is a major change. It is not really just a tool for the experts, but for any anesthesiologists who are willing to learn to use the tool. I asked my friend, Dr. Franco, I said, you published these papers and you have such high success rate. Why do you need ultrasound? He has changed. Well, he told me again, is the empowering feature of ultrasound. You see what you're doing. It's the local anesthetic spread that makes a difference. When we compare ultrasound with nerve stimulation, I don't believe that we should compare the experience of two experts, one experience in ultrasound and one experience with nerve stimulation, because that shouldn't matter, because they are already so good in what they do. What this study looks at is residents, those who are just beginning or those who do not practice regional anesthesia all the time. When you combine ultrasound with nerve stimulation, the time to do the block, the number of needle attempts, the number of vascular puncture and block failures are all in favor of ultrasound. I think that's where we should focus our attention. Also, ultrasound has improved the safety in some areas. I want to qualify this statement because ultrasound is very good in detecting intravascular injection and intraneural injection in superficial locations. When it's a deep location, it becomes more difficult. So this is a clear indication that the injection is extravascular. You see the pool of local anesthetic injected here, so it cannot be intravascular. When you see the nerve swell in size as you inject, it tells you it is an intraneural injection. You pull back the needle and finish the injection. So those are things that nerve stimulation cannot tell you. It is very hard to show the benefit in randomized controlled trials because most of the complications occur so rarely. And this large registry, over 14,000 patients, look at nerve injury and accidental intravascular injection. For seizure incidents, definitely less now when ultrasound is combined with nerve stimulation. But looking at nerve injury incidents cannot show any conclusive evidence. This is again a big outcome database. It does again show that the incidence of intravascular injection is less. Again, ultrasound has its limitation. Don't feel that ultrasound can do everything for you, particularly when the block is performed in a deep location, in this case, parasacrosciatic block. Cardiac arrest can still happen because you don't see where the local anesthetic goes. Intraneural injections can still happen because it depends on who the operator is. As you inject, if you don't scan in the right place, you don't see the injection is intraneural. So still can happen, not so much blame on the machine, but on the operator. In the past few years also, you see that there are many studies on the uncommon blocks. People want challenges. They find that ultrasound for upper limb blocks, lower limb blocks are already commonplace. There's no challenge there. So people have to find challenges, have to find something more to do. So they're looking at tiny things. They're looking at the eye, using ultrasound for the eye block. In fact, the eye is a nice chamber filled with fluid. You can see the optic nerve. But if you do that, make sure that the output, there is certain output that you don't want to exceed when you do the eye, image the eye, because it may heat up the fluid. So that's something to remember. You see this superior laryngeal nerve block. I don't usually do it for my airway instrumentation, so I don't believe that that will be very helpful to me. Yes, you can see the great auricular nerve in this tiny nerve. again, is it going to be helpful in your practice? Infrapatellar nerve, another small nerve, innervates the knee. So those are the things that appearing in the literature. You have to ask, is that relevant in your practice? I don't think that this is our future. I don't believe that unless in a very small group of practitioners who need to do these blocks, I don't believe that is the future. There are other things like the X-ray nerve. I think that would be probably more useful because in patients that you don't want to do the interscaling block, you can now see the nerve in this location in the upper arm. The PAC block that has been reported with some success for pain relief after breast surgery. More data need to appear to see whether that is going to be a useful technique. And you also have heard a lot of so-called the adductor canal block, really as a saphenous nerve block that helps with the knee analgesia without causing muscle weakness in the quadriceps. So those, again, I believe are more promising future blocks that we'll study in order to define their role. What we also know is there are things when we are using ultrasound, we still don't know for sure. So things like how much volume to give, the minimum effective volume, the optimal injection technique for certain blocks. What is considered the optimal local anesthetic spread? Do we need to surround the nerve with local anesthetic every time? How can we improve nerve imaging, particularly in the deep area? And also needle tracking still can be a major challenge. When we look at minimally effective anesthetic volume and the dose, we have to ask, is it clinically relevant? There are talks already during this conference that say, how much do you use now with ultrasound? So I'm going to just go over some of the data. For X-ray block, it is true, you can achieve success, a successful